one case where, I kind of fumbled through it. I don't know if it was right, but we really needed a wound care specialist, and that's when it finally started hitting us that we need to do something. And I think the wound care team is not just isolated to critical limb ischemia from diabetes. I think it's trauma also, like our plastic surgeon this morning said. This was a 6-year-old girl that was somehow got run over by the lawnmower that was operated by her father, and you can see the extensive, it was a popliteal injury for us. Yeah, we were able to go ahead and repair that, and orthopedics was able to come in, but the soft tissue defect, she's going to need big help with the plastic surgery and coverage, as well as some way to rehabilitate and get back on her feet, because it's going to be a long rehabilitative process for this young girl. The bottom line, yeah, the hospital says, yeah, that's all great, you want all these people, but what's it going to do for us? And I think that's going to be one of our hurdles. How are we going to facilitate reimbursement, professional fees, growth, potential, and so forth, and make it worth everyone's while? And so I know there's going to be a lot of hurdles that are still in place, and especially the fact, OR time, we're talking about bringing in extra people and having cases and shared, so forth, research, availability, data management. And these are all things that we're trying to think through, but at least now we finally start the process. So hopefully next year, if I come back and talk to you again, I'm already advertising for my presence, but by then, we should have something in place in terms of our limb salvage team. Thank you.
Next to the podium is Dr. Joe Mills from Baylor in Houston, who will tell us about his program both in Tucson and in Houston. Joe?
Thank you. There's going to be almost no science in this. I'm going to try not to overlap too much, but this model kind of grew out of just observations that took me a long time to make. And again, I used this slide earlier, but so when I trained in the Air Force in vascular surgery, it was a really strong vascular program, and we did a lot of aortic surgery and carotid surgery and very few lifts. I only saw one vessel below the knee in my entire residency experience. I did 33 open aortic reconstructions in 3 months as a chief resident, and I did about that many carotids. All of a sudden, I landed. So the year I applied for vascular surgery fellowships was the year they were first accredited by the ACGME. So all the programs I applied to weren't accredited yet, and I found this one in Oregon that was accredited, and I went up there to do John Oregon example. So I go up there expecting to do aortas and carotids and all that fun stuff, and we have leg after leg. I did 100 distal bypasses with Dr. Porter, 104, something like that, as a fellow. And so when I went back to the Air Force, they said, well, that's all cool. We don't have distal disease here. You're not going to see that. So good luck with that. So the year I was a fellow was the year that Bandig wrote the paper on graft duplex scanning. So I started looking around, and we had a transplant service. We had a lot of renal failure patients, a lot of diabetics. And I just started asking the internists and the orthopedists and the general surgeons that if they had a diabetic foot, let us just see it. So within about 6 months, we were admitting all to our service. And after a while, we'd have 15 or 20 patients like that on our service. And we pretty much started doing lots of legs. So that's when I started the first multidisciplinary thing. So let me skip over some of these we talked about. So then I moved to Arizona, same thing. It was mostly relatively modest practice of aortas and carotids and a few legs. And we got that going pretty quickly because there was demographics on our site. So we had lots of Hispanics, lots of elderly because lots of people moved to the Southwest to retire. So aging and being Hispanic increased your risk of having diabetes. And then we had Native American populations we served, some of which are almost all diabetic. So I started working in the same way I always had. And we realized a couple things, that we were only seeing the part of the, even though we were busy, we weren't seeing all the patients that could potentially help. And then we were missing a key component. So I would do, for example, a stem perineal on somebody with an infected foot after I trained it, get their transplant to heal, might require a skin graft like that case that Vince showed, and then see the guy back every 3 months for a year, every 6 months for 2 years, and periodically monitor his bypass graft for surveillance. And then I noticed he had a sore on the bottom of his foot, and his foot was in a Aquinas, and he was walking around, and I thought, geez, I don't know how to take care of this stuff. And so we hired David Armstrong. So we started working together, and it dawned on me about this time that if you're going to do this, you really need to partner with somebody who gets the foot. And I learned a lot about the foot on my own, but I'm still not the same as a podiatrist. And podiatrists pay attention to blood flow, but they don't think about blood flow the same way that vascular surgeons do. So why not partner up on every patient? And the other reason that's important is I think that the disease has changed. So when I trained with Dr. Porter, we did patients with diabetes, but we still had a lot of patients that were just smokers. And it was a pure plumbing problem, pure ischemia problem. And it took me years to figure this out, but I kept thinking, patients are changing, the disease pattern is changing, we'll get to the next bucket of it. But there's not so many patients that are just neuropathic anymore. A lot of these patients are neuroischemic, right? So when I first started doing the diabetic feet, most of the patients, we just drained their infection, offloaded a little bit, took off a dead toe from infection, they healed. And through all those patients, we filtered out the few that needed bypass. Then I started noticing that more and more of them were needing bypasses. Then I started noticing that endo was happening. So trying to figure that out. So it seemed to me, you needed to add the component of things that the vascular surgeons don't do. So we did that in Arizona. I'll show you a little bit of data on that. And then there's a couple papers. So Dr. Randy Indican, the role model with David and I were talking, he got invited to give a talk. So you know, David talks a lot, and he travels a lot. But he said, hey, look at this talk. It's all about vascular disease and diabetes. This is cool. And I said, well, we're looking at the pamphlet. And he shows me the pamphlet, and there's one vascular surgeon on that pamphlet. And I thought, well, who's doing the vascular part of this? And I look at it, and it was all people that I didn't recognize. And I've been kind of involved in this field for a while. We're all interventionalists, though, what I probably shouldn't say pejoratively, but lesionologists. And so the message was clear. Podiatrists were starting to recognize that more and more of their patients were ischemic. They wanted help with them. And for whatever reason, in the broad community at large, they didn't have access to or weren't aware that there were vascular surgeons that really cared about this. And industry was pushing devices, right? Because there's all these new techniques we have. We now can stick, like my partner Miguel showed you, can stick a tiny needle in an artery in the foot and wiggle a wire up backwards and get a blood vessel up. It's kind of a magical procedure, right? So that's all pushed by industry because we still don't know which of those techniques work for which patients. And I'm pretty sure those techniques don't last long enough for lots of patients. So anyway, the point was to marry podiatry and vascular surgery together. So we started with that simple concept. So when I was looking at a job actually at University of Chicago, and I didn't take that. And then David called me one day and said, hey, what if I come to Arizona? So I talked to my chair, and he goes, well, you can do that. Sounds like a good idea, but I don't know anything about podiatry. So he'll be in your division. You figure it out. So So I hired David. I get a call from one of my best friends who's the chief orthopedics. He says, what the hell are you doing? You hired a goddamn podiatrist. And I said, well, John, we're just going to take care of diabetic feet. He's not going to do he's not going to mess up your other practice. Oh, just diabetic feet, that's okay. So nobody really cares. It's kind of interesting. But this was a study that came out of Duke, I think. It basically looked at the impact, and vascular surgeons like to think we save all these feet, but we save the ischemic feet, but we don't save that big iceberg that's diabetic feet. They're not all just ischemia, right? There's all these other things you have to do to actually not just get them to heal, but keep them healed. So this was a study that basically looked at if you saw a doctor plus a podiatrist in the last year, your risk of getting complications went way down. So that's prevention, which vascular surgeons don't do, right? Where the guys with their finger at the dike, when the patient comes in, they already have a problem trying to save a foot at the end of the line, right? But what if you had people helping you up front to try to prevent some of that? So that's probably where podiatry comes in. And then this is how we developed our model. Basically, I was really upset that people were focusing so much on the arterial anatomy and the lesion. It's like when the patient comes to you, they don't come to you with an angiogram and says, here's my anatomy. They come to you because they have a sore on their foot. And usually that sore doesn't hurt because they've lost the gift of pain, right? They've had loss of protective sensation. So they come in with a sore. And you have to sort out, is there ischemia present? Is there enough? I really have to correct it. If I have to correct it, what's the best way to correct it? But you also have to take care of the architecture of the foot. You may have to do some correction there. Video offloading is not going to be enough. And so how do you stage that limb and figure out how to deliver this care? And then, actually, it's sort of backwards. So before you assess the limb, you actually have to assess the patient first, right? Because the patient comes to you, not the limb. The limb doesn't walk into your office. The patient comes in. So you need to know about their support network, how functional they are, what their comorbidities are. Then you get to the limb status. And then when you do all that stuff on the subset that looks like they're going to need something to heal their wound, then you get into the anatomy. But our specialty, partly driven by great results with bypasses and identifying distal targets, and then pushed by lesionologists who are developing techniques to treat all these lesions, started focusing just on the arterial lesion, which I think was backwards. So I'll skip over that. So basically, we had a simple concept. Why not just put? So what we did was, it took me 2 years. We got a clinic with 2 parallel hallways, and the vascular lab was in between. And we didn't care who got the patient first. If podiatry got the patient first, or vascular got the patient first. And the same with inpatient consults. The same approach for inpatient and outpatient. We both saw the patient, and we used a precursor of Wi-Fi before we developed Wi-Fi to kind of sort them out. So they kind of fit into 3 groups. There's the obviously well-perfused patient who has a warm foot from neuropathy. They have a hole over a bony prominence. They've never been offloaded. They have a normal pulse. Almost no matter how you measure their blood flow, it's okay. They mostly need a podiatrist. And then you have the opposite of somebody because of 3 dead toes, and maybe actually have rest pain. They don't have any infection yet, and no matter how you measure their blood flow, they need a vascular surgeon first. And then at some point, maybe a podiatrist. But then you have all these patients in between. So we'd see them all, and we'd put them in 3 groups. And if they were a toe group, the toe team would take over and take care of that patient, and we periodically retest their blood flow. It was obviously ischemic. They got that corrected immediately. And then if they were in between, we took a variant approach. So if it was a smallish wound that hadn't been offloaded well, and we thought the care wasn't really standard, and the blood supply wasn't bad, we would take really good care of that wound for a while, try to get the patient back. And if they were responding well over about 2 to 4 weeks, then we'd just keep treating the wound. If they got good care and were adherent and we were stalled, then we did something about the blood supply. So that was sort of, then when Wi-Fi came out, we now use that. So I've done this now in the Air Force, in Arizona. I'm trying to do it 2 different settings in Houston. So part of the reason I came to Houston was because it has a huge population of patients with diabetes. And nobody in Houston has ever cared about lower limb stuff. It's been the center of the cardiac and aortic universe for 50 years. And the primitive system they had in place for foot care is shocking, actually. So we do the same thing. I partnered with a podiatrist I met when I first came there who wanted to do this for a long time. I'd never found a vascular part. I finally hired him. He's a great doctor. He sees patients. We talk all the time. We try to stage every patient. Sorry? Oh, Jeff Ross, yeah. And then, so the other thing that's really, really, really important is infection is the highest priority, not ischemia. So if they have infection, that needs to be controlled first, and it even needs to be drained. Even if it's ischemic, if there's drainable infection, you got to drain it. So we do that. Vascular does that, podiatry does that. It kind of depends on who's free. Then we get their ischemia worked up properly and figure out where they are on the Wi-Fi spectrum. If they need blood flow, then they get blood flow. And then we talk together about who's going to manage this foot. Then the other key point to Wi-Fi that isn't been appreciated is you should restage the patient. It's just like TNM for cancer. So many cancers now we used to operate on get chemo first or get radiation first. And then before the next stage is planned, after that round of chemo is done, patients restaged, right? So there used to be Nyquist protocol for anal rectal cancer. And so when that first started, I was a resident, patients would get the chemo, then you go in there and do an APR on the patient, and abdominal resection, and people started noticing, hey, there's no cancer left. So that chemo worked for some cancers so well that the surgery was no longer necessary. So the same point here, there's a paper that's just about to come out that's presented at the Southern. So they actually looked at the Wi-Fi score 1 month after you start treating the patient. That actually was a higher predictor of limb loss than what they were at baseline. So the point is, if you're doing everything right, and you're revascularizing, and you're still not getting anywhere, you may not be able to save that leg. So it's taken me 2 years, despite the fact that it was in my contract. We just are about to start our clinic where we all work together. So we started out by just putting the podiatrist in the vascular clinic, but then you're mixing wound patients with carotid patients with other patients. It's not really efficient. And they had a separate wound clinic that was basically run by internists without any surgical involvement. And that wasn't working very well. So we finally got that all together. So the second thing I'm trying to do is Harris Health. So Harris Health is one of the largest indigent health systems in the country. So there's 1.2 million people out of the 6 million or so that live in the immediate Houston area. They're eligible for Harris Health care, but they don't all come in until they have a problem. So they have a dedicated internist. There's an endocrinologist who started a wound clinic, does a really good job with it, but there's only one vascular surgery funded by entire Harris Health system. And so a lot of the patients, the traditional model for care there was nothing got done until it got really bad. They came in the emergency room, and the Baylor tradition was the general surgeons could do everything. So they would drain the person, give them 1 shot at the foot, and if that didn't work, they got a BK. So there were over 200 BKs the first year I got to Ben Taub in 1 year. So what we started there is I started meeting with them every month. And we now have an ID person, an ortho person, 3 vascular people, the vice chair of the department. So I started meeting with all these people to try to organize a limb disorder. So now we're using Wi-Fi triage in the ED, and patients are getting vascular assessment before they get sent home or before they get an amputation. So that's a whole other. And then one thing I didn't talk about was when I tried to do it Baylor, there's another issue with antibiotics. So the traditional model at St. Luke's was if you had any problem with your foot, you got admitted. And then whichever person happened to be consulted would do the best they could. So you might have an orthopedist consultant, you might have general surgery. If somebody thought there was ischemia, it might be cardiology, it would occasionally be vascular. There was no rhyme or reason to it. And a lot of patients got admitted actually just had chronic neuropathic wounds with biofilm on them and didn't really need anything for admission. They just needed a coordinated workup. So we're trying to fix that. This is funny. So this I got from Dr. Montero Baker. So Vince mentioned nutrition. So this is the St. Luke's nutrition model. I'm sure this patient's diabetic. This is the McDonald's that's in the St. Luke's Hospital. It's a 24-story building. It's huge. And then the point of all these things, it's somebody just cleaned the floor, which is kind of funny to do right in the middle of the day. But these are all the barriers you have to go through to get resources from your hospital to try to do this stuff. And the only way you can do it is you have to. The hospital actually gets this as a problem, but they try to convince them to do something about it. It's really hard because it takes resources. So you can't quit. You just have to keep beating on them. And it also helps you if you're not beating on them by yourself. So if you get an ID person, a couple of podiatrists, a couple of vascular surgeons, and you get a group of us, say we have a coordinated way. We're going to avoid admitting some of these patients. The ones that get admitted will actually get a coordinated workup, so they don't spend forever in the hospital. We can do better. So we just started the Safe Extremity Program STEP, and Ed Olmos was actually nice enough to come to DEF CON that we had in Houston for the first time. So anyway, I mentioned for Ben Taub, I was meeting with him every month. So I went to the first M&M there. Ken Maddox still runs that. And I flipped through this. They call them protocols, but every service has a list of all the cases they did for the week. So I flipped through every week, and I would look at anybody that had a toe amputation, a foot debridement, a BK, an AK, an angiogram, a leg bypass. And what was stunning to me, so Houston is the most diverse city in the country. So over 30% of the population was born in another country. So there's huge ethnic groups of all varieties. But by far away, the most common patient that was threatened was Hispanic. So there's a lot of working people in the Houston area that are Hispanic, and their insurance have to take them there. So in the context of going once a month to meet with these people, this McCrory grant comes up. So we submitted a huge grant for patient-centered outcomes research to look at ethnic and racial disparities, which I thought Harris Health would be a perfect substrate for. And we got turned down for that. But they liked the idea, and they said, look, you're not really looking at ethnic disparities. You're looking at how to design a healthcare system, which is probably what we're trying to do. Right? We're trying to take the resources that we have in Harris Health and figure out how to use them to get patients the kind of care that they really need. So we're going to try to use Wi-Fi to stage patients, and then we're going to try to branch out and have some of the patients with lower risk limbs be treated in a primary care clinic to offload the centralized wound care clinic they have now. So that's part of what that is. But anyway, I think I covered all that stuff. So in Arizona, basically, this is what we were able to do. This was when I hired David and one other podiatrist. These are the monthly clinic volumes. So we got up to seeing 10 to 12,000 patient visits a year. And Tucson's not a big place. Pima County's only a million. And so that's not individual patients, but that's patient visits. So we did that in about a 3-year period. We looked at what happened before and afterwards. So this speaks to the neuroischemic thing. So 1/3 of these patients over 4 years ended up being revascularized, which is pretty high. We did endo first on about 64% of them. And we already had a pretty low amputation rate, but it got even lower. And what also happened was we increased the number of non-urgent procedures. So we were doing prophylactic things to offload patients to like PAMA head resections. I never would have done those before I met David. So by working together, we improved the care for the patients. So the final thing I want, so you got to set up the system to take care of a chronic disease, right? And that's not how our healthcare system is designed. Our healthcare system was designed to take care of disasters, right? So we do great with trauma, like that case Vince showed. Best trauma care in the world. We have Children's Hospital, we have Ben Taub, and if you're injured in Houston, you get first-rate care. But if you have a chronic disease, not so hot, right? We treat a chronic disease like it's an emergency. So what we do, we wait till the problem's really bad, and when the patient gets in the ED and they have a stage 4 limb, we're trying to save it. And that doesn't make sense. But the final message is this. This is from Stefan Rohrbach's group. And so in Europe, the advantage Europe has is they have patients in healthcare systems, so they can actually design a system that works. That's why the limb salvage rates are so good in Italy, for example, because they see patients right away and they get triage. So this was from Rohrbach's paper. Basically, when we take care of these patients and you show that EO foot, that's not a cure. They're in remission, right? Because they still have diabetes, they still have neuropathy. Even if you corrected their ischemia, there's no revascularization that's immortal, so they're always at risk to having a recurrent problem. So just because you fix them the first time, if you don't have a system that can help maintain that, the recurrence rate cures over 90% in 10 years. So for the patients that we keep alive longer with diabetes, you're not done with them. So your limb salvage center is actually going to have to expand because you're going to have to start following these at-risk patients to prevent recurrence. Because if you don't, we're going to, Mike's talked about this, but the epidemic of restenosis, that doesn't even get to the epidemic of recurrent lesions in these patients. So it's a big problem. So I think the message is you got to find somebody to work with. So Dr. Ross and I actually operate together. Sometimes it sounds kind of weird, but I revascularized a foot, and I was maybe the one that trained because I was on call. I kind of like to be around to see what's going on, and we teach each other stuff, and we learn from each other. And sometimes one of us will recognize, we had a guy in the hospital that Miguel and I revascularized 4 times. He had primarily distal disease, wasn't really a bypass candidate, and his foot just wasn't making it. And I thought, I'm not sure this is as good a foot as we can get. And I went back and touched up this little minor pedal stenosis. And finally, we take him to OR to debride him, and there's a pocket of undrained infection there. We both missed it for like a week. We were seeing this guy every day, and I was fixated on the fact that it wasn't responding because the blood flow wasn't adequate, and the reason was there was still infection. So the point of that is we all make mistakes. The other point is if you work together, you're more likely to find them. So working together is good for the patient, and it's really a good profession. I have so much more fun when I have a group of people I'm working with and working for the same goal and we're trying to do better. So thank you very much.
This program contains graphic images and discussion of medical procedures. Viewer discretion is advised.
This is a 60-year-old gentleman with a history of diabetes, end-stage renal disease, on dialysis, hypertension, hyperlipidemia, PAD, who presented to the vascular surgery clinic right before Christmas with a black toe. He's had an inciting event that led to the black toe. He was chasing his dog at the beginning of December, and over the course of a few weeks, it just continued to get darker and darker. He went to a Kaiser ED where they treated him with betadine paint, sent him on a PO course of antibiotics, and recommended that he see a vascular surgeon. So he presented like this to our clinic. A little bit more about him. Again, his illnesses, as you can see, his medications. He had a fistula last year, and he had Charcot reconstruction on his foot in 2010. You can see his x-rays here, all broken screws, and he has a 30-pack-year history of smoking. My physical exam, he did not have cellulitis. He was afebrile. He did not have a leukocytosis. Clearly, you can see dry, stable gangrene of the second toe. His vascular exam is non-palpable. He had non-palpable pedal pulses. He had monophasic DPPT. His non-invasive studies, you can see below here. His toe pressure was 32, and his Wi-Fi stage was 3. Okay, I'll open it up to the panel. How would you proceed with this patient? Vascular and podiatry? Vascular?
Well, I think the good news is that he had a successful Charcot reconstruction, and you don't get Charcot without adequate circulation, so you've got to know that 2010 he had adequate circulation. So we know that this has progressed in his later stages. That's the good news. The bad news is that he is also on dialysis, and dialysis gives you that more distal, as Joe pointed out, and Mike pointed out, the infrapedal disease that we're seeing more of. So obviously, you can do lots of studies here, but in my opinion, I would do an angiogram straight away with 3 views of the foot.
Okay, very good. Here we go. That's what happened. He was admitted to the vascular surgery service and had an angiogram. And I can pass that off to Dr. Gaspers. Let's see.
All right. Well, as you can see, he actually has a very large exophytic plaque in his common femoral artery. I don't know if you can point to that, Nicole, but he did have a palpable pulse, but realized that a little bit distal to this, it actually became significantly weaker. Then you can see his SFA is patent but heavily calcified. If we go to the next, he's got this very heavily calcified popliteal, and then this focal occlusion there in the above knee pop. And then down below in the tibial arteries, he's got anterior tibial runoff, and his TP trunk is reasonable, but then his posterior tibial and perineal are sort of small. And if we go to the next, then both of these, posterior tibial and perineal, are coming down to the ankle, but really it's his anterior tibia that's dominant until it gets to the ankle, and you kind of get a sense here. Unfortunately, we just have a lateral view, but it really is kind of stopping as a bunch of small collaterals, but perfusing the dorsal surface of his foot. You can also see this perineal is providing a posterior branch there to what's left of his posterior tibial.
No, not bad. Stop. Go higher on the foot.
No, what that is, that's a little bit of a Photoshop magic to try and get that plaque to show up.
Like a stop. So that's where I think ultrasound helps you, because you see those exophytic plaques all the time, right? So they're not all it's not. So what's this waveform the SFA and the pop like the wheel?
We don't have the waveforms there. No, that focal occlusion. Well, right. I mean, up to sort of the distal SFA, yeah.
It's just like that, but you look ugly, but when you look at the dynamic part of it, it's not going to be so that's without any attention. But it is, it's that. Plus something else. So Joe, you got the common femoral lesion, you got the distal above knee popliteal lesion, you got the anterior tibial artery lesion, so you got 3 there. So the question now becomes, do you take care of 1, 2, or 3 of them? I'm retired, so you'll have to answer that. This guy question is walking.
Yeah, he's chasing his dog. He's 60 years old. He retired recently, but he was an active guy. He's an active guy.
Is that common femoral disease was significant? I do that open, and I treat the population and the same thing. That's what I got.
Okay.
So
if the common femoral lesions were significant, I would never recognize that. That popliteal lesion is really focal. I'm pretty sure I get that open, and I need to put it alone and see what my reproduction was like before it did. This is dry.
That was dry, correct? Yeah.
Might be enough. There's actually lots of field disease like this. You don't always know what's going to happen when you do the top part. If it's not enough, then you go back to that. Why not just do the top part alone? Well, the popliteal part also can be restricted. Sure, that picture of the top.
There you go.
That's like some worse reason. Is everybody time to chime in? I'm not thrilled with that calcified popliteal lesion. I think you can get it open. I don't think it's going to look very good. I mean, this guy doesn't have any nerves. He's got his dangerous toe. So I think short bypass graft would be a better solution. But he's got that origin anterior tibial lesion. You're not going to leave that, are you, Mike? Yeah. I am. I think I'm going to do the contract my daughter and take that issue with that popliteal level of the cat.
Okay. That's what happened?
Well, right, so as it turns out, this guy, we actually randomized him to best CLI, and in keeping with my cosmic wishes, he was randomized to open. So we did a femoral endarterectomy, and then ended up, his conduit was a little bit on the short side, so we did a dog. We came off his mid-SFA to below knee pop.
He also had a concurrent second toe amputation, which I closed, because he had decent perfusion, and his met head looked clean.
He's got a 3-med code. Well, he's going to be at risk for coming before that, right?
Yes, so here's post-op day 3. He was discharged on PO antibiotics. He had home health services, changed his dressing 3 times a week, and then came into clinic 1 week later with a dehisced surgical site, which I don't have a picture for, unfortunately. There was 5 of us in the room, and nobody thought to take a picture, but just because you can't see it. So he dehisced his surgical site. His second metatarsal head was looking at us. I could probe to his third metatarsal head, and the tissues were more so dry. He really didn't have purulent drainage, a little bit of purulent drainage, but at that point, his leukemia had progressed, and we were worried about an infection at that point in his foot. So,
Did he get a DP pulse after the bypass? Or some sort of distal pulse beyond the AT origin?
Yes, he actually had a palpable AT pulse right above his ankle, but then, he lost it as it became the DP on the dorsum of the foot. But he
So he kept his popliteal pulse?
Yes.
His graft was open, and the lesion that was not bypassed occluded or became dysfunctional.
No, I think it was more that he didn't have a true DP going on the dorsum of his foot.
Oh,
so he had a palpable AT above the ankle.
When this happened?
Yes.
Okay.
How did the toe bleeding go?
it was actually pretty decent. That's why we closed it and did not leave it open. At the sulcus.
Well, as it got infected, drained it. Let's line it. Okay, so reassess the line. First thing. Then the second issue is just timing. So usually, if it's a dry lesion like that, there's no infection, and happens by vascularization, kind of makes sense to take it all at the same time. But on people,
Why does it make sense?
there's no pretty much bad.
Other than that.
The argument against it is that you don't always know how much reperfusion you're going to get immediately when you haven't drained everything. So there is an argument, and I've seen that with SPY, where in their initial deciding read is better, but not as good as it is a week later. So sometimes it's better to wait a little bit. See that point.
If you had the experience of when you revascularize them and don't do the amputation, but wait a few days, that they demarcate and you wind up taking off less?
I've had the experience that demarcate makes it more clear. I think that waiting for 3 days or 5 days or 7 days is arbitrary.